Oh, bom dia, Pedro.
I'm afraid I don't have your audio back. Good morning, everybody. We have a busy room here. We started very early. It's a nice case we got for discussion today. I have here on my right André Spadaro, Eduardo Manhães, Cristiano Guedes. The room is full of people here. Michele Gallon there, Daniel Chamier, you know very well. We have the whole team, and Paulo Soares is here. Perhaps Paulo could present our case for today.
Hello?
Hello.
Are you listening to me?
Yes.
Okay. The slides, please. Okay. So this second case is a 6-year-old male with hypertension and hypercholesterolemia. Next, please. And in 2000, he was admitted to the hospital with stable angina, and PCI was performed with BMS stent in proximal LAD. He was asymptomatic after that, and the past 6 months he started having angina again. And he's now on aspirin, atenolol, simvastatin, enalapril, and omeprazole. So we perform another angiogram that showed no lesion in left main and circumflex. Next, please. And a restenosis in LAD, and a severe stenosis in the ramus. Next. You can see again the restenosis and the severe lesion in ramus. Another view. Next, please, the spider view. Next one. He has normal left ventricular function and a very small right coronary artery. Okay, so I'm gonna move to Pedro to start the case.
So you see here that it's a patient with recurrent angina 12 years after having his stent implanted in the LAD. We got this film done a couple of weeks ago, and 2 lesions to justify the angina. We got the restenosis in the LAD and the tight lesion in the ramus. So we had this discussion, which one of the 2 lesions, if not both, would be the responsible for the angina. What do you panel think? Perhaps we could show to you the image that we got today. Vamos mostrar, André, desde o começo? Não, é só ir para frente, vai para frente. Mais fácil.
Você não está ouvindo?
Não. We got this nice software that we are using over the last days and weeks from Philips. With one injection, you can see the whole coronary tree in a swing way. I still don't have the audio back. Ainda não tenho o sinal. No. With that, you can do the 3D reconstruction. Can we go to the next one? You see there that there is a tight lesion in the LAD. The stent is in the mid of the stenosis. It seems to me that we have plaque just after and before the stent. No. Next, please. So you have the plaque going up to the ostium and down up to the mid LAD. And there is a diagonal branch. Tá bom, pode parar. Volta anterior. So I'm afraid I don't have the audio back. Eu não estou ouvindo eles. Oh yeah. Now I see you. Eu ouço.
Good.
So welcome, Pedro. A couple of questions. Is this in-stent restenosis of a bare metal stent or DES? You said that this stent was implanted 12 years ago, is that right?
That's right, 12 years ago, so that's a bare metal stent, Alex.
Pedro, you have the LAD, restenosis, the diagonal involved, and then the ramus. Are you using 3 wires?
Frankie, good morning.
Good morning.
We plan to do the LAD first and then the ramus. So we cross the diagonal and the LAD, treat that first, and then go to the ramus. But before going to the treatment, we got this question if we have a real restenosis there, or if it's stenosis, plaque before and after the stent, or neorestenosis because it's 12 years back and the patient has got pain again only 6 months ago.
Yeah. So when you have the bare metal stent restenosis, are you planning, I don't know whether it's available here in Brazil, the drug-eluting balloon, but your strategy would be just dilating it or put another stent in?
That was our question. If we had only a pure restenosis, then we could go for a balloon, drug-eluting balloon. We did IVUS before. I can show that for you to you in a minute, just to see if we got stenosis pre and post stent. And then if we got that, we decided to go for a drug-eluting stent instead of a balloon. Can we show the IVUS to them?
Raised the question of whether the lesions were significant. Did you think about using FFR to be controversial?
Yeah, no, I think that's a
Another
great
question is, this is a bare metal stent restenosis. It's significant, but not too severe in my mind. Also, it was implanted 12 years ago. How we can recognize this is the development of this restenosis? Yeah. I mean, it may be not contribute to the...
Here we go.
Yeah.
So we have
I think this is a very good comment. Maybe it's just progression in other sites that cause the angina and not the stent restenosis itself. But let's see what Pedro has to say about the IVUS.
Yeah, can you have the IVUS there?
Yes. Can you go ahead and describe it? There is nothing there. No intimal hyperplasia so far.
And a very good lumen.
I'm sorry. O primeiro puxada.
That's the final, right?
You see here the baseline, actually. Yeah. We started very early here today, Alex.
Yes, it looked so good that there's no instant restenosis there. That's good. Pedro is using the volcano.
Yeah, there's something there distal.
So that's the baseline, pull back. That's the diagonal. You see that's a very a calcified lesion. Still pulling back. That's a volcanomechanic catheter, 45 megahertz. We're using for the last months. You are in the mid of the previous stent. You see here that there is, and now you're out of the stent, so there is a tight and very large plaque just in the border of the stent, outside of the stent, and that goes up to the ostium of the LAD. Perhaps I have the joystick here. Let's see if I can stop that. And pode parar a imagem para mim, Valdir, por favor?
These volcano images now. I think they did a lot of improvement with
that's a volcano image, and I got this joystick here that very helpful actually. So that's the stent. It's a previous stent. There is restenosis here. You see that's a tight lesion inside of the stent, but you also have this plaque, which is a
huge plaque burden. Positive remodeling, very eccentric plaque. There is fibrosis. But most get lipid soft plaque. But
do you think that the stent is underdeployed, Pedro?
Yes, very much, very much.
I mean, 12 years ago, you know,
yeah,
12 years ago we didn't really know much about, I mean, these high pressure things. And I'm just wondering, you know, bare metal stent restenosis, there's always a possible reason with under expansion of the deployed stent.
Yeah, the mechanism of restenosis there, perhaps a combination of lack of expansion and intimal hyperplasia, because there is tissue inside as well.
Yeah, but that new lesion really is outside the stent, so you also have that inlet osteal lesion.
At the proximal edge.
I think that it's underexpanded, and you see here that you still have the IVUS, you do. You have the stent struts, and you have calcified plaque behind the struts. So it used to be calcified also at that time. Most probably that was the problem at the time too, dilate this calcified lesion. So we decided to treat the whole segment in the stent and outside of the stent too. Therefore, Eberhard, we did not use the drug-eluting balloon in this case. Would you agree with that?
That's great.
Yeah. When it goes beyond the stent boundaries, I have to say that generally, drug-eluting balloon wouldn't be my first choice. I think when you have a more focal, or mainly when you need more expansion, I think that you do aggressive pre-dilatation and then just put a drug-eluting balloon to massage and perhaps to deliver drug. But when it's proliferative like that, I think that you might be committed with another stent. Any different comment? Ricardo? Another stent.
Miguel?
Yeah.
Miguel? Any comment?
Another stent, right?
Yeah, another stent. I have some doubt about calling this a restenosis. 10 years later.
Yeah, it's perhaps another mechanism. I think it's lesion progression.
Progression is more like it.
So what kind of drug-eluting balloon? Which industry is it?
Drug-eluting stent. Drug-eluting balloon, we have two here. We have Sequent, please, and we have Dior. Both paclitaxel.
Dior, okay.
It's available here in Brazil. It's B. Brown and Eurocorp.
Before going to the stent. Yep. Mm-hmm. Yeah, before implanting the stent, we took care and we did a good pre-dilatation of this lesion because we didn't want to implant the stent and then had the bad feeling of understanding that we cannot expand the stent after implantation. So we could not cross the lesion with a cutting balloon first. We did a gentle pre-dilatation with a 2O balloon. And then we use a 3O cutting balloon to do this pre-dilatation. Perhaps we could show the expansion of the cutting balloon. Vai para frente, Eduardo, por favor.